No.
No. Yeah. Sound far away. Yeah.
You're going to have to hold it close right up to your chin.
Right into your lower lip. How's that?
So you got to hold it right up to your lips.
Okay. How about that? Hey, there you go. Okay. So today I'm going to talk about the updated TB screening, testing, and treatment guidelines that came out this year in 2019. So I'd like to begin by discussing the history of the CDC recs for preventing TB in healthcare. So in 1994, the first guidelines came out, and then they addressed healthcare facilities. And then in 2005, another set of guidelines that came out with exactly the same title, except for instead of healthcare facilities, now we have healthcare settings. And then this year in 2019, another set of guidelines came out that is really quite different and addresses screening, testing, and treatment. So the 94 guidelines were written in response to a resurgence of TB in the mid-1980s and 1990s. Several healthcare-associated outbreaks due to increase in the prevalence of TB and HIV co-infection, lapses in infection control practices, delays in diagnosis and treatment, and the appearance of multi-drug resistant TB. So the result of that guidance was a decrease in the number of TB outbreaks in healthcare settings and a reduction in the number of healthcare-associated transmissions. So this graph is the TB incidence in the United States from 1953 to 2017. And the blue arrow points to the resurgence in the 1990s and 1980s. So you can see how the guidelines hopefully helped decrease. So this is the original TB facility risk assessment from 1994. So it was more of a flow chart design. So you were first to review the public health data from either TB patients, and if there are no TB patients, then you're considered minimal risk. If your community has some TB patients, you would move on to PPD testing. If a cluster or evidence of person-to-person transmission was suspected, then you would need another hand here. Move on to the next slide. Evaluate causes of transmission. So if a cause could be identified and corrected, meaning you retest at 3 months without additional conversions or transmissions, then you are considered a lower risk. If the cause could not be corrected or identified at all, then you were considered a high-risk facility. Very low, low, and intermediate risk facilities were those based on 0, fewer than 6, and 6 or more TB patients admitted to the area during the preceding year. This risk assessment has 4 or 5 different categories of risk depending on how you want to look at it. And it seems a little complex to the one we're used to. So based on your facility's risk classification, a corresponding series of administrative, environmental, and respiratory protection control measures were detailed. So this is the table here. Page 1, 2, 3, 4. I'm sure you're all familiar with the outline of the TB program as it was given to us in the 1994 guidelines. So then in 2005, because of the diminished healthcare risk for healthcare-associated transmission of TB, the new guidelines came out that emphasized actions to maintain momentum and expertise needed to avert another TB resurgence and eliminate lingering threats to healthcare workers, which was basically latent TB. So here's our graph from 2005. blue arrow is pointing to 2005, so you can see we're still decreasing. So we went from a single page flow sheet to a 6-page risk assessment worksheet. The real meat of this worksheet is really within this red box here. And that was our low, medium, and high risk classification. So we went kind of from 4 or 5 different risk classifications to 3. So in these recommendations, and I'm sure you're all quite familiar with these, facilities where that had less than 200 beds in outpatient facilities that encountered or evaluated less than 3 TB patients per year, or inpatient facilities with 200 beds or more that encountered 6 or less TB patients, were considered low risk. And so low risk facilities would do baseline testing for TB upon hire, but then not annually. So medium risk facilities were those with less than 200 beds in outpatient facilities that encountered 3 or more TB patients per year, or inpatient facilities with 200 beds or more that encountered 6 or more TB patients per year. So these facilities would screen upon hire and then at least every 12 months. So I know at the end of the year, everybody's holding their breath, depending on your facility size. Hopefully we don't, we're low risk next year, right? So who should be included in the TB surveillance plan according to the 2005 guidelines? Well, they say all healthcare workers whose duties involve face-to-face contact with patients with suspected or confirmed TB disease. And so who's that? All these people. So for many healthcare systems, this is tens of thousands of employees annually. And the financial and manpower burden to screen all of these people is quite hefty. So this brings us to the 2019 guidelines. So these guidelines were written because since 1991, TB in the United States has continued to decline. Non-US born persons accounted for approximately 2/3 of these cases, and serial TB testing has limitations in low-risk populations. So the recommendations from the 2005 CDC guidelines that are outside the scope of screening, testing, and treatment and education, they all remain the same. So this guideline just kind of supplements the 2005 guidelines. So this graph is depicting the number and incidence of TB from 2010 to 2018. So a total of 9,105 TB cases were reported in the United States in 2017, and this is a 2.3% decrease from the number of cases reported in 2016, and the lowest case count on record in the United States. So this map depicts TB case rates in the United States from 2017. So 39 states, that's the yellow states, reported a rate of greater than or equal or less than or equal to 2.8 cases per 100,000 population, which was actually the 2017 national average. 11 states, the District of Columbia, New York City, reported a rate of greater than 2.8, and that accounted for 59% of the national total in 2017. So this is a map of Indiana and surrounding states with the rate, number of cases, and rank for each. Rank was assigned according to the rate. And Indiana had about the same rate as Michigan, Ohio, and Kentucky. Illinois has the highest rate on this map, and Wisconsin has the lowest. Nationally, the highest rate is in Hawaii, with a rate of 8.1 per 100,000, and the lowest is in Montana. Okay, so what's new with the 2019 guidelines? So there's an individual baseline risk assessment. So this is to supplement the facility risk assessment, which you still want to do, but now there's an individual risk assessment. There's symptom evaluation and testing of persons without prior or latent TB. No routine serial testing in the absence of an exposure or ongoing transmission. It talks about treatment for healthcare workers diagnosed with LTBI, annual symptom screenings for persons with untreated LTBI, and annual TB education for all healthcare workers. And here's a table of some of the changes. So it compares the key changes in the 2019 guideline with the 2005 recommendations. So remember that the 2005 recommendations that are outside the scope of the 2019 guidelines still apply. So we talked about a little bit about the individual baseline TB risk assessment. Post-exposure testing hasn't changed. Treatment is encouraged for all healthcare personnel with untreated LTBI now, as before. You were just referred and treatment as indicated. And then there's a recommendation for some annual education that we'll talk about. So the individual risk assessment includes a questionnaire, symptom evaluation, TB testing if indicated, and perhaps an additional workup. So individual TB risk assessments are superior to screening all healthcare workers due to extremely low rates of TST conversion in low TB incidence areas, and the IGRA and TST have limitations for serial testing. So this is the questionnaire, or the individual TB risk assessment that's contained in the 2019 guidelines. So healthcare personnel might have risk for TB exposure that are not related to work in the United States. So the first question, did you have temporary or permanent residence for greater than 1 month in a country with high TB rate? And that would be any country other than Australia, Canada, New Zealand, the United States, and those in Western or Northern Europe. Or current or planned immunosuppression, HIV, organ transplant, treatment with TNF-alpha antagonist, chronic steroids, or other immunosuppressive medication. Or close contact with someone who has had infectious TB disease since the last TB test. So this would be like an exposure in a healthcare setting. So the second point is that healthcare facilities might consider using serial TB screening for certain occupations. So if we talk about our list of occupations from the 2005 guideline and try to pare it down to just those high-risk occupations, the ones that are highlighted here perhaps might be considered high risk. Staff who do bronchoscopies, dental staff, ED staff, laboratory, pathology, respiratory therapists, people who participate in aerosol generating procedures, and then we kind of added pulmonology and then maybe urgent care staff. So the guideline indicates that education should be annual and include risk factors, signs and symptoms, and it should direct healthcare personnel to discuss any occupational or non-occupational TB exposure with their primary care physician or their occupational health, and that would be based on that individual risk assessment that we just discussed. So for evaluation and treatment, if there's a newly positive test, this might be at your baseline testing perhaps. A secondary confirmatory test is recommended for those at low risk. Symptom evaluation, chest radiograph, and perhaps additional workup. If there's a prior positive TB test and a normal chest radiograph, repeat chest radiograph is not required unless the patient is symptomatic or starting treatment. And then if the patient has LTBI and no prior treatment, it should be offered and strongly encouraged, and the patient should be strongly encouraged to complete treatment according to the guideline. Personnel who do not complete LTBI treatment should be monitored with annual symptom evaluation, and you should educate about the signs and symptoms of TB disease so that they can seek immediate evaluation should signs and symptoms appear. And then healthcare facilities are urged to collaborate with public health agencies to assist in achieving this goal. So now let's talk about the guidelines for treatment from the American Thoracic Society, IDSA, CDC, and CDC. So this is for the diagnosis and treatment of TB. So this document stresses that individuals affected with MTB may develop symptoms and signs of disease or may have no clinical evidence of the disease. So new cases of TB will develop within these groups. Major focus of this document is of elimination and control, and aim of testing for LTBI to identify those who will benefit from prophylactic therapy. So this table is a paradigm for the evaluation with people with LTBI based on risk of infection, risk of progression to disease, and the benefit of therapy. So the clinician should weigh the likelihood of infection with the likelihood of progression to tuberculosis if infected, and then also the benefit of therapy. So household contacts or contacts of those involved in recent exposures of active case have the highest risk of infection according to this paper, or this guideline. And children under 5, HIV infected, and those on immunosuppressive therapy, those who have an abnormal chest x-ray consistent with prior TB, or those with silicosis are at the highest risk for developing disease if infected. So these are the patients who would most likely benefit from LTBI therapy. So while both IGRA and TST testing provide evidence for infection, they cannot distinguish active from latent. So there are benefits and limitations to both. So for TST, the benefits is that it's simple, it's low cost, there's no need for phlebotomy. With IGRA, it's specific, it can be performed in a single visit, and there is some regulatory certification that needs to happen in order for this test to be conducted. For TST, the limitations are that you need trained personnel, there's variability interpretation, requires a return visit, there are false negative and positive results, and it's complicated interpretation. And for the IGRA, the limitations are the cost, the need for phlebotomy. It also has a complicated interpretation and inconsistent test reproducibility. That being said, there are some recommendations about which test to use. So if we begin at the bottom of the table next to the blue box, you'll note that the guideline does recommend testing for LTBI in people unlikely to be infected. The guideline does not recommend testing for LTBI in people unlikely to be infected. This would be based on the individual risk assessment and job category that we just discussed. The preferred test for people unlikely and likely to be infected with low to intermediate risk of progression, and these are the blue and yellow box, is IGRA where available, although TST is still acceptable. Moving towards the red box where the likelihood of infection and the risk of disease progression is high, IGRA or TST is acceptable in adults, but TST is preferred in children. So confirmatory testing is recommended for both positive and negative results in all three of these categories. So a second diagnostic test when the initial test is negative is performed to increase sensitivity of the test. If the initial test is positive, you want to do a confirmatory test to rule out a false positive test. additional workup could include symptom evaluation, chest x-ray, and testing for disease. We already talked about those. So patients suspected of having pulmonary TB, you want to do AFB smear rather than not do an AFB smear according to this guideline. Both liquid and solid cultures, and then a NAT. And then in patients who have previously been treated for TB, born in or have lived at least 1 year in a foreign country with at least moderate tuberculosis incidence or high primary multi-drug resistant tuberculosis prevalence, or contacts of patients with multi-drug resistant tuberculosis and HIV infected people, you want to make sure that you do drug susceptibility testing. So treatment of LTBI. Healthcare facilities should aim to identify LTBI among healthcare personnel and encourage LTBI treatment. Isoniazid reduces the subsequent development of TB disease in patients at high risk for progression. There are 4 treatment regimens for LTBI, but the shortest, most convenient regimen is the one that should be prescribed. There are 2 major benefits to treating LTBI. One is that it prevents the progression to active TB disease, and that prevents transmission of the disease in the community. So these are the 4 latent or LTBI treatment regimens. So you notice that the duration is either 6 months, 9 months, 4 months, or 3 months. But then the frequency is either for the 3 months weekly with a total of 12 doses, and then you can see the total doses going down on the right-hand side of the table. So I think it's pretty clear from this table that if you can prescribe the 12-week treatment with isoniazid and rifampicin, then you should. Because it has substantially higher completion rates. It's safe and effective as other recommended LTBI regimens. And it's recommended for people aged 2 to 7, and it can, people with HIV or AIDS, patients that are on antiretroviral medications can also do this regimen. And it can be either DOT or self-administered. So this is material you can get right off the CDC website. It's developed for clinicians to use with patients that are prescribed the 12-dose regimen. There's space to write treatment schedules, medication intake, doctor clinic contact information. And then there's also a checklist of signs and symptoms that might develop while you're on the drug, in which case you want to seek medical attention. And these are just some more customizable resources from the CDC to kind of promote the 2019 guideline. Some more social media graphics aimed at treatment of LTBI and the individual risk assessment. More CDC stuff. So the Parkview experience. So we have about 3 conversions annually across all Parkview hospitals. PRMC, PVH, PWH, and PLH are all considered medium risk, and that's primarily due to their LTAC beds, and all other sites are low risk. And we have a low incidence in the community. So this is not in writing anywhere besides here yet, really, but this is our plan. So we plan to stop the annual TB testing for low-risk employees this year. We'll be developing, or it's already been developed, a computer-based learning module that will include the annual education as well as the individual risk assessment that we talked about earlier, with where coworkers at high risk will be directed to their primary care physician or occupational health. And when I say no data collection, we're not scoring the risk assessment and following up on the answers. We're leaving it to the employee to go seek testing if necessary based on this risk assessment. So additional high-risk employees that may continue to get the annual screening are listed here. These are the same ones that were highlighted in the 2005 table. Put a question next to dental because I don't think we even have dental. So that's it. Any questions? Yes.
Thank you for the presentation. My name is Anna Roy. I work as an infection control nurse and employee health nurse in a small hospital. And I loved your breakdown of the new guidelines. I haven't really read it that well yet, and I was wondering if there's a way we could have a copy of your presentation to review it.
Yeah, I think that's good.
We usually post these on the Board of Health website, so you can go there.
Okay.
If
So
it's okay
just
with-
Fort Wayne Board of Health, that's how I find it?
You go to the Allen County Board of Health.
Allen County, okay.
And it won't be there, I'll send out a blast when it gets put on the website.
Okay, great, thank you.
Or send an email to either Elaine or myself,
Right.
and we'll be happy to
Thanks, Doc.
Right
get
away.
that to you.
Did I see another hand?
Just on your high-risk testing for those groups. You
Those
guys
job
are,
categories?
right,
Okay.
you guys are doing the IGRA, right, for that?
I think that's the plan. Mhm. Yeah, we already do with the annual, I think we're just doing it. Any other questions? Thank you so much.